Welcome, everybody, to the webinar, Integrating Emerging Research in Biofilm Management, Targeting the Biofilm Structure. This program is provided by North American Center for Continuing Medical Education and is supported by an educational grant from the Next Science Group. I'm Dr. Matthew Regulski. I am a senior partner with Ocean County Foot and Ankle Surgical Associates in Toms River, New Jersey, and I am the medical director of the Wound Institute of Ocean County, New Jersey, in Toms River, New Jersey as well. And thank you, everybody, for taking your time out to come learn about this very interesting and emerging science and also this very devastating topic. The learning objectives that we're going to cover today, as you can see on your slide, will be numerous, they will be in-depth, and they are complex. Biofilm is a very complex structure. It can do a lot of nasty things to the tissue in which it encompasses. We know that 90% of chronic infections are found within biofilm. So it's very important that we know how to treat biofilm, as this is a very, very difficult entity for us to resolve. So we will begin discussing the science of the biofilm, very fascinating topic, very molecular and complex. But once you understand the gist of how biofilm works and how the chronic inflammation that it does stimulate and the ability for it to break down tissue and perpetuate chronicity and to advance inflammasome activation, not only that we see in the wound bed, but in chronic inflammation will underlie a whole host of age-related chronic diseases, including diabetes, cardiovascular disease, obesity, and neurodegeneration as well. So there is a very interesting concept that chronic inflammation does underlie. As we look at infections and the money that this is costing us, and how much in penalties that a lot of institutions have to pay for readmissions for these problems. Perhaps if we have better technology so that we can treat chronic infections and prevent readmissions, not only will we do a good service for our patients, but we will do good service across all medical specialties, period. I think that it is very difficult for us to understand and to comprehend a lot of things that are going on and the variables that are going to be encompassed by patients and all their different comorbidities. But it is clear that we see that, especially in postoperative infections and, of course, in chronic wounds, which are typify what a chronic infection is, costs a tremendous amount of money, to $30 billion a year for these for not only post-op infections, but chronic infections, and then when patients have to be readmitted because we didn't deal with that infection in the first place, makes us, how should we say, very amenable to treatments of this nature so that we can rid our patients of this problem. The cost, again, especially for Medicare patients, is becoming quite staggering, approaching the treatment cost that we see in the treatment of chronic wounds for diabetic foot ulcers, around $36 billion, venous leg ulcerations, around $34 billion a year. But when we see how many people are readmitted each year, it's getting to be quite staggering in the cost that it does. So we have to find better ways of dealing with this problem. With 10 trillion bacteria on our skin, anytime we make an incision on people, we can open up biofilm and stimulate biofilm formation. So we need to find a way to deal with this, be able to disrupt this biofilm and destroy this bacteria and prevent its reformation without hurting good tissue. I think the numbers that we see for people that are suffering from chronic wounds, over 6.5 million people, are even going to grow even greater. Around 2030, 1 out of every 5 people in the world are going to be diabetic. Those numbers will reach this country in about 2050. We see people with venous leg ulcerations. Over 1 billion people in the westernized world now have a venous leg ulceration. Diabetic foot ulcerations are the #1 reason diabetics are admitted to the hospital. And the money that it costs for treating a diabetic foot ulceration, around $27,000 to $35,000 a year, it's even growing because a lot of people now wait because of high copays and co-insurance and deductibles, trying to treat things themselves, and they wait till things get way out of hand. And we are starting to see a lot of severe end-stage disease. So the money is going to be growing. The money that we're going to need to treat this problem, we are running out of because this problem is even growing probably exponentially. So we need to identify these problems that occur within the chronic wound bed so that we can prevent more of the admissions to hospitals and the amputation rates and the morbidity and mortality from this, because any lower extremity chronic wound carries almost a 30% all-cause mortality. 47% mortality on diabetic foot ulceration. These are numbers that are greater than most cancers are. So as we progress through this overview, we're going to talk about these things that you see here, all these lists of problems of how a biofilm starts and why is it so destructive and how can we attack a biofilm, because it is very difficult for us to do that. Biofilm is almost impenetrable to our own white cells. We know that antibiotics itself, oral antibiotics, can't heal chronic wounds. We've seen people that have had 6 and 7 different rounds of antibiotics by the time they come to us because we can't get these flow rates out of the plasma high enough to penetrate biofilms without destroying the patient's kidneys. So we know that antibiotics do not heal wounds because the biofilm makes it virtually impossible for these antibiotics to get through there. So we need to do something better, something based off of science and based off the evidence that comes with that, so we can destroy, disrupt, and prevent that reformation. The normal wound healing paradigm is very complex. It is extremely fascinating. It's very contextual. And we know that these are the ordered steps of it, as hemostasis, inflammation, angiogenesis, granulation, epithelialization, and remodeling, and the time that it takes, and the different types of cells that are going to be involved in it, and also the different types of proteins that they are going to be secreting. And we always talk about chronic inflammation as these wounds being stuck in chronic inflammation. I've often wondered, what does that mean? What does that mean on a molecular level that is going on? And when we start to look at all of these fascinating perturbations that are occurring within the chronic wound bed, where we have things such as there's lack of a blood clot, there's lack of that provisional matrix that is going on, excessive inflammation that we start to see, where proteases and their counterparts are imbalanced. We have defective, degraded ECM. When we start to see failure of keratinocyte migration and failure of fibroblast migration because they have become senescent due to exposure by this chronic inflammation, the reactive oxygen species that are flying around, creating DNA damage response within these cells, and then converting them over to a senescent phenotype where they fail to migrate and become pro-inflammatory and a highly metabolic activity. When we start to see the failure of cells adhering to the ECM because the ECM is being degraded by the chronic inflammation, the growth factor receptors are being broken down. That's why we see a lot of chronic wounds have those very round, fibrotic, rolled edges that you see. And then there's going to be excessive scarring that occurs, and of course, tremendous amounts of biofilm, very thick, robust, nasty, aggressive, hungry biofilms that we find within these chronic wounds. So that's what we mean when we start to see why it's being stuck within this inflammation, and how do we progress that on. When we start to look at chronic wounds and why do things not progress, there are certain factors that we do look at. Why these factors then lead to a perpetuation of chronicity. And as you can see, there are multiple ones for those. And we know that all chronic wounds have a hypoxic gradient to it. If we had adequate oxygen going on within that wound, then we would have collagen synthesis, angiogenesis, resistance to infection, and epithelialization, because oxygen is a cofactor for a lot of these processes. Making new blood vessels, it's a cofactor for making good, strong collagen. It's necessary for cells to respond to secrete their proteins that they need. So all chronic wounds, as we know, are going to be hypoxic. Ischemia reperfusion injury is another big field that is starting to be opened up for study. And it means that classic sense is when you start to have an occlusion of blood flow to a specific area, whether from embolus, from a thrombosis. And then it creates a tremendous hypoxia. There's a metabolic imbalance between the supply and demand of nutrient factors getting to this tissue. And then paradoxically, when we reestablish the blood flow into the area, can exacerbate tissue injury and lead to a prolonged inflammatory response and activation of cell death programs, such as apoptosis, necrosis, and autophagy-mediated cell destruction. So this is becoming a new field of endeavor, but that's occurring, and that is happening within our wound bed. Intrinsic host factors, people that have significant comorbidities. Diabetes leads to immunosenescence, meaning that their white cells don't respond as violently as they need to destroy pathogens, to repair tissue. Because remember, your white cells are not only critical to remove invading organisms, but they are critical to the repair and regenerative process. They lead to the sequestration then of inflammation, because inflammation needs to be controlled, it needs to be regulated, it needs to be specific to the stress that we are trying to mitigate, and then it has to be resolved in a very ordered pathway. And when that's not, then we suffer the pathologies of chronicity. So our white cells then need to come in, and then they need to remove the pathogens, and then they themselves start to secrete factors that convert inflammation over to a more proliferative paradigm. And that's just putting it very superficially. It's incredibly in-depth. We could talk for hours and hours and hours just on that itself. But these different types of these intrinsic host factors that these patients have, whether it be specific disease states, autoimmune disease, maybe they're malnourished, if they're heavy smokers, and we know that smoking has significant impacts upon wound healing. For one smoking one cigarette reduces tissue oxygenation 30% for 1 hour. So you think about your patients that have been smoking for 50 and 60 years. And of course, one of the big ones that we're talking about today is being that biofilm. And that biofilm then leads to chronic inflammation because it stimulates our own white cells to come down to the area, and they're trying to release hydrolytic enzymes, and those hydrolytic enzymes are bouncing off that biofilm, degrading the ECM. So the biofilm and then the white cells consume all the oxygen within the wound, because our white cells like to, through the oxidative burst, that's how they release those hydrolytic enzymes, so they're consuming molecular oxygen. But so at the same time is the biofilm. And as we can see when we get into more pictures of the biofilm, the bottom layers of biofilm, these thick, deep layers, they're very hypoxic and full of anaerobic bacteria. So those are some of the factors that lead to very poor healing and then allow us to suffer these states of chronicity. When you look at biofilm, it is like an iceberg. We know that 90% of all the chronic wounds have significant biofilm, and in fact, most bacteria that we're going to be harboring, that we see in these disease states, are harbored in biofilm. And it does look like the iceberg. You know, the tip of this iceberg, yes, is planktonic, free-floating bacteria. But as you get down through the biofilm, remember the biofilm itself, there's only about 20 to 30% bacteria. The rest is all EPS. It's all that extracellular polymeric substance. It's not filled to the gills with the bacteria, okay? I think that's a misconception of what is going on there. It's this very difficult EPS, this sugary film that's around there, was what leads to the significant perturbations in our inflammatory signaling and in our inflammatory cascade. And as we get down deeper into that biofilm, these bacteria are much more resistant because a lot of times they switch their phenotype over to an anaerobic bacteria. They've competed against each other. They've consumed all the oxygen. That's why the aerobic bacteria are just in the surface. They can't live, obviously, deeper, but that's where these things called persister cells will reside. And they are mostly anaerobic bacteria because it is a very hypoxic core, but biofilms can extend very deep. They can get down and they can get around adnexal structures like sweat glands and blood vessels, and can be several millimeters thick. They can kind of extend down into that deep subcutaneous tissue, looking like your fingers projecting down into those deeper structures. Make it very, very difficult for us to be able to remove effectively and remove the inflammatory nidus. Now, how does biofilm establish? And it has to find some kind of a surface for it to adhere to. And I think that one of the big things that we see when we talk about putting different things into a wound, like the old wet to dry gauze dressings, why they're so ineffectual. That bacteria can traverse 64 layers of gauze. Very interesting fact that I discovered years ago in trying to research all these different types of bacteria and the chronic inflammation that they purport, so that they have something to adhere to, some type of a surface. And then once they start doing that, then they start aggregating together. All these different bacteria come together. Remember, you have over 10 trillion bacteria on the surface of your skin. You have 100 trillion in your gut right now, but they have to adhere to a surface, and then they start to grow. They start to consume because they are competing for space in here. And so obviously there is the aerobic bacteria will consume all the oxygen that is going on in there, and then they start to talk to each other, this quorum sensing phenomenon, which is just fascinating, and how they can horizontally gene transfer back and forth. So you could take a normal skin contaminant, such as Staph epi or Corynebacterium, and it can acquire some of this virulent genetic material from Pseudomonas and some of your Group A and Group B streps and different types of bacteria, and become more virulent, as we see a lot of Corynebacterium and Staph epi and biofilm based off DNA culturing. And so then as these colonies start to grow and form, and then they can release their own proteases. So portions of this biofilm then can break off, and then they become these fully formed biofilm communities that can travel through the body until they adhere to another surface. And they can start to grow and multiply and then create its destruction and create havoc throughout other parts of the body. That's how they disseminate their infection throughout different tissues in the body. Very, very just a very fascinating procedure as how it can sense this when the competition within the space it is starts to exhaust their nutrients, and then they can secrete those proteases that we talked about, and they can start to move and start to travel throughout the bloodstream to different parts of the body. That's why we see a lot of people that get endocarditis and spinal abscesses from and spinal osteo when they have infections, particularly diabetic people. So, remember, the biofilm does not want to kill the host at this point. The biofilm wants to releasing different types of proteases within the wound to break down the extracellular matrix, to allow a lot of that wound fluid to percolate up through the wound bed, because that's what it survives on. That's how it gets its nutrients. So it wants to be able to feed off the host, if you will. So that's why it likes to stay in that inflammatory period, because we're releasing all these degradatory proteins so that we can break down the tissue and survive on that. And then, of course, your white cells, again, are trying to come down, and they're banging on the biofilm, and they're releasing hydrolytic enzymes, and they're not being able to penetrate the biofilm, but they kind of think of it as bouncing off and degrading the ECM as well. So when we talk about why it is stuck in that area, because it benefits the biofilm for that, so that it can survive, and then it can percolate, so to speak. And as we're into inflammation, and we see the different problems that are going to be occurring in there, and the different molecules that the biofilm triggers, because remember, those on the EPS and bacteria, they do have certain types of proteins, right? Gram-negatives, you have LPS. Gram-positive, you have cell wall teichoic acids, and that will trigger receptors on the surface of every cell. Big ones are toll-like receptors. You might have heard toll-like receptor 4, which triggers that cascade to stimulate NF-kappa beta, which is your master regulator of inflammation and apoptosis and also immunity. And it triggers that because it will control the transcription of over 125 pro-inflammatory genes as well. And then those inflammatory substances start to get producing, and they perpetuate chronic inflammation as they have a bystander effect. And they can have a systemic effect when chronic inflammation is percolating throughout our body. That's why we see people that, with obesity, for instance, can underlie the inflammation that leads to metabolic syndrome, diabetes, cardiovascular disease, because of these cells become chronically inflamed. And when the inflammasome gets activated, then you secrete a myriad of these different types of pro-inflammatory molecules that can have a significant effect, causing apoptosis and senescence within the entire body. So the biofilm then itself, again, with all these different types of reactive oxygen species and the effects that those have, causing DNA damage within cells, affecting DNA and protein and lipids, and creating this chronic inflammatory cascade. It's really a kind of a signaling feedback loop where they continue to perpetuate that inflammatory phenotype And then as the biofilm grows and they engender the EPS, and that production of it encapsulates itself within these sugar moieties and protects it from the environmental stresses, protects it from the immunological phagocytosis that is occurring by the host. And ultimately, it can, again, render the body more susceptible to other types of infections in the body, because it can lead to immunosenescence as well. So when we start to look at how that biofilm actually creates these problems, and it's really a protective layer. It's kind of like a force field around the bacteria, right? The bacteria will produce this, and then the bacteria kind of go into an arrest mode. They kind of, after they've consumed what oxygen is in there, they get into an anaerobic phenotype, and their metabolic pathways and their metabolism slow down significantly. So the biofilm is a protector. It provides nutrition. It can give some hydration to that area, but it's a place for these bacteria to have a holiday, to sort of grow and feel protected. And when it feels like they're in a domed stadium, so to speak, right? They have that force field around them, which is incredibly difficult for our own immune system to get through. It's incredibly difficult for a lot of antibiotics orally to get through, to get those concentrations high enough so it can prevent our immune system from coming in there and releasing all these different types of hydrolytic enzymes to destroy it, to degrade it. That's the problem we have. It's hard for us to disrupt this biofilm and then destroy the bacteria, but even more importantly, to prevent that reformation. So it provides a safe haven for the bacteria to grow and to wreak its havoc. So what exactly is this biofilm that we've been talking about? And for years I've wondered exactly what this structure is. We hear people throwing out these terms about it and what's encompassing and how does it grow? How does it mature? What is that structure like? How can we attack that structure without hurting good tissue? Has always been the $64,000 question, if you will. So again, the biofilm is this community of these pathogens enclosed within a structure that is composed of the different types of sugar bonds. It's mannuronic and glucuronic acid, and it's usually linked with a metallic ion. And a lot of times we will see it in wounds as being more of an iron molecule. A lot of times in sinus, you'll see it as a calcium molecule. There are some talking about cystic fibrosis type biofilms have a zinc molecule that is in there, and that's what holds it all together. Now, if you think back to your organic chemistry days, that when you tried to burn sugar, so if you looked at table sugar, sucrose, that has a melting point of about 337 degrees. When you look at glucose, that has a melting point of 295 degrees Fahrenheit. So very difficult to break those bonds. So in order for us to unzip that biofilm and expose those hibernating bacteria inside. But I think of it as a big fishing net, and the knots within the fishing net are going to be those metallic ions that we have just talked about, and forming this entanglement, this spider web, if you will, of encasing structure to allow the bacteria to grow through the protection that it provides, and nutrition and the hydration that it provides for that. The strength of this is very difficult to get through, and all these different terms about this extracellular polymeric substance and the glycocalyx, some people have called that. What exactly does that mean? And so obviously it's going to be extracellular. We have this noncellular type gel that's secreted by bacteria to provide that physical barrier, and then they get encased in that. And it's very difficult for our white cells to get through that because their enzymes aren't strong enough to dislodge those metal ions, to break down those different types of aldehyde-type bonds that we see within there. And that's what we mean when we say polymeric, because it's all these different polymers inside the gel become linked then with these metallic bonds to give it that heightened strength and that structure that can be quite resistant to our immune system. And then when we talk about those metallic bonds, and you can see the colorations of them holding and linking all of these polymers together is that once these metallic bonds become established, then that substance converts to a very insoluble capsular environment that interacts with that host for the growth and the maturation, the proliferation, the nutrition, for the survivability of the bacteria to flourish in these areas, and then to wreak the destruction that it does in maintaining the wound and inflammation so that it can survive of all that percolating wound fluid. Here's a classic example of what biofilm does look like. And as you can see how these structures start to look just like a fishing net. And you can see the metal ions that are there and the bonds that it does create. And then when we start to see that 90% of that bacteria are enveloped within the EPS. Now, inside that EPS, of course, it's not full of bacteria to the gills. A lot of that bacteria resides in an anaerobic phenotype, so its metabolism is significantly reduced. But it's this structure here that gives it the strength and gives it the character to survive. So if we can find a way to destroy this structure, to disrupt this structure, and then expose that bacteria, blow them apart, and then prevent the reformation, because remember, the biofilm will start to reform in as early as 30 minutes after you sharply debride. And it can be fully mature in up to 5 hours afterwards. So preventing the reformation is going to be quite critical in destroying the biofilm and ridding the area of this. So we talk about these bonds and these polymers that are there. They give it to the strength from being washed off or being eradicated by different chlorines or PHMB, things that have to be able to get itself through that biofilm, because we have to find a way, I'd like to call it unzipping the biofilm. It's a good, easy way for people to understand that if we can take those metal polymers, if we can find some way to pull them out into solution, we will rip apart the EPS. Then we can expose those persister cells, those anaerobic bacteria that are hiding deep in there, and be able to blow them apart. And then those fragments of the biofilm that we've unzipped, and we need something perhaps to coat them to prevent them from sticking back together, and thus that will lead to preventing the reformation of the biofilm. So I think that is going to be critical for those things that we talked about. How do we block the formation of this? How do we prevent the diffusion of these different? How do we increase the diffusion of these small molecules into that area to destroy that? Because we have to find a way to open up the biofilm, and I think that's what's critical about this technology, is because this technology can bind to these polymers, it unzips the biofilm, it coats those polymers to prevent them from sticking back together, and it will cause swelling of the bacteria, blowing them apart, and thereby preventing that reformation. So the EPS is a fascinating structure. I encourage you to learn about it, because it's not only in chronic wounds, but you're going to see it in people with recurrent cystitis and cirrhosis and gastric ulcers, COPD, emphysema, cirrhosis of liver, chronic inflammatory diseases have biofilm. Atherosclerotic plaques have been shown to have biofilm. So it's an amazing structure, and if this technology can do it here, I'm sure that it can do it everywhere. Also, if you start to look at herniated discs, they're seeing a lot of Propionibacterium acnes in the disc that leads to its degeneration, its inflammation, its weakening, and then also leading to bulging and herniation. So that's a very interesting finding about that you can see in disc disease as well. So how do we target this structure? I think how can we remove and certainly that we have to do sharp debridement. I think the sharp debridement, right? We're removing that slough. Now you cannot see biofilm. No matter what people say, you cannot see it. That slough that you're seeing is the sequelae of the chronic inflammation, of the destruction that goes on, of the tissue degradation, all that slough that is going on there. Because have seen several wounds itself that may have a nice granular base, but at the same time there might be a sheen over the top of those, and that could be that sheen that you see can be sometimes encasing biofilm in there as well. So it's very difficult to see it, but all that slough, debris, the degradation that we have is going to be a picture of the result of having biofilm. So how do we target these pathogens? The free-floating planktonic bacteria, obviously, are the ones, when we say planktonic, that they are able to divide and grow. We see them on the surface because there's a lot of oxygen on the surface. They're usually an aerobic bacteria. And then as we progress down through the EPS, as more bacteria accumulate, and they're going to compete for the space and the nutrients, they exhaust the oxygen that is within the wound, and that's why they become more anaerobic in these deeper layers and these persister cells, and they reduce their metabolism, which means that it does make them more resistant to antibiotics, because antibiotics need to have multiplying bacteria in order to be effective in there. So once we remove the planktonic bacteria, how do we expose the anaerobic bacteria that are hiding within the EPS without destroying good tissue? And then how do we create within that environment a way to prevent this from reforming? And then thus, by removing the biofilm and that nidus of chronic inflammation, then we should be able to progress these wounds on into more of a proliferative, a healing phenotype, to removing the chronic inflammation, all these different types of stimuli for our immune system that's going on, and all of these senescent cells that are in there. Because remember, it only takes fibroblasts to have 10 hours of exposure to this oxidative environment to induce a chronic wound senescence and a chronic wound phenotype within the cells there. So we know that in the wound bed, all of these cells are going to be senescent. They need to be debrided out and removed as well. But how can we do that without destroying more tissue and allowing them to have better cell migration? The trends that we start to see in the biofilm that we talked about, obviously, is that we have debridement, and it's critical to have debridement. You have to be able to remove these different types of all this stuff that has to be removed out of the wound, whether you're doing sharply, mechanically, whether you're using a Versajet. Well, we have to do some type of debridement, but the point being with debridement is that sometimes we don't get everywhere. Sometimes, it's hard to see. How are we deep enough removing the biofilm, right? We're eyeballing all this. We don't have an electron microscope with us. We're not doing some type of Mohs procedure going on so that we can see we have all of the biofilm that has been removed. So thus, debridement is a tool, but at the same time, we need to put something back on there so that we can prevent that reformation for it. When we talk about different types of dressings, I don't know any type of dressing that has been out there to show that it can prevent, can destroy biofilm, or thus prevent the reformation of the biofilm. We use a lot of these different dressings to absorb that slough, to absorb the drainage, because the drainage is highly inflammatory, obviously. It's full of proteases, it's full of dead cells and damaged tissue and things that can trigger inflammation, right? And we know that we have to be able to wick all of that drainage off of the wound. Otherwise, we're going to lead to breakdown and maceration. And thus, this wound fluid is full of fibrinogen, so that's the protein that feeds bacteria, and that's why we get a lot of odor. But at the same time, we have to be able to watch that we're not inducing cytotoxicity. We know the problems that come with silver can induce cytotoxicity. We look at iodine-based preparations, and long-term use of those has also been shown to lead to significant inhibition of cell migration and cell function. When we start talking about peroxides and chlorhexidine in the long-term use, and also obviously betadine, can lead to decreased cell function because they can be quite cytotoxic when they're used in a long-term capacity. Some great studies showing even iodine preparations like iodosorb, 48, 72 hours use of that can show significant reduction in fibroblast function. So we have to be careful about the different types of things that we are using and that we are putting onto the wound for those. So I think when we start to look at what we need something that can disrupt the biofilm, blow it apart, unzip the biofilm, whether it's going to be bacterial, whether it's going to be fungal. And fungal biofilms are very difficult to eradicate because they are very thickened and very hard to penetrate, very tight biofilms because of their chemistry and the different polymers we find in there. And we have to be able to not only destroy bacteria, but we have to prevent the reformation, the barrier effect. But we have to do it in a way that doesn't harm good tissue, and at the same time, there's no way for us to get some type of a resistance mechanism to those. So I think with the Next Science technology, we encompass these parameters of having that broad spectrum against bacteria and fungi, and not having a way for these pathogens to have a resistance to that. It's compatible with our tissues, not interfering with the healing process, and we have the sustained capability to prevent the reformation, to have that continued barrier function for it. So I think that is one of the most interesting things about this technology that you learned and that you're going to learn, that it has these capabilities of disrupting the biofilm, preventing the reformation for that, because as we unzip those metal ions and we pull those polymers out into solution, the citric acid and the sodium citrate buffer that solution. They maintain that pH around 4. They can bind those polymers and prevent them from sticking together. And then the benzalkonium chloride that comes in will swell the bacteria and blow that bacteria apart. Thereby we disrupt, we destroy the bacteria, and most importantly, we are going to prevent the reformation of the biofilm, which is critical to allowing these wounds to progress on into a healing phase, and then epithelialize as well. And that's our goal in this field, is to get as many patients as we can to be healed. So at this point, I'm going to stop right now. This ends my portion of my presentation. I want to thank you for your time, and I hope I have stimulated you all so that you can really investigate in biofilm and the therapies that are there. Thank you very much for your time.
Thank you, Dr. Regulski. My name is Susie Seaman. I am a nurse practitioner and certified wound, ostomy, and continence nurse practicing in San Diego, California. I will be presenting the next portion of this webinar. Here are my disclosures for your reference. Today, I will discuss a new technology to break up biofilm and destroy bacteria in chronic wounds. I will also present the results of 2 clinical trials examining the use of this biofilm-disrupting wound gel in the treatment of patients with chronic wounds. After that, I will describe how to use this product in caring for your patients, and we will end today's program with a review of some real-world case studies in which I used this biofilm-disrupting wound gel. So let's get started. First, let's talk about this new science-driven treatment. It has simultaneous actions. As you saw earlier, in terms of the goals of disrupting biofilm, we need to target the structure. We also want to target the pathogens and kill them off. And then we want to control the environment. We want to provide a moist for healing to occur. So this particular product has 4 main ingredients. It has citric acid, which is a chelating agent and a buffer, sodium citrate, which is a buffering agent, benzalkonium chloride, which is a surfactant and an antimicrobial, and then PEG gel, which is basically a hydrogel, and it maintains that moist wound environment. So this structure will look familiar to you, as Dr. Regulski talked about this. And this is that very tough structure that protects the bacteria inside of it. This is the biofilm. And it has these long polymers, these macromolecules that are held together by metallic bonds, and those are the blue areas in the structure. Now, the way that this product works is that the citric acid in the gel binds to the metallic bonds, and the sodium citrate buffers the solution to maintain an effective pH. So let's look at this a little bit more closely. If you look at this little picture right here, basically the gray and the purple are the polymers. The blue are the metallic ions that hold the polymers together, that maintain that strength of that structure. And then the orange is the citric acid. And basically the citric acid attaches to and removes the metallic bonds that hold that EPS structure together. So the polymers are then released into solution. And then sodium, which is created during this reaction, actually binds to the polymer ends and caps them off so that it prevents the polymer from reattaching. So we've destroyed the structure. Now we need to destroy the pathogens. And the sodium citrate and the citric acid both produce an osmotic pressure that distends the bacterial cell wall. And then the benzalkonium chloride basically comes in and kills the bacteria. It attaches to a protein in the cell wall and then aids in cell lysis. And then lastly, we want to prevent that biofilm from reforming. And so this particular product will create a physical environment that prevents attachment of those free-floating planktonic bacteria and then prevents the biofilm reformation. The gel also, again, provides that moist wound healing environment. So we end up reducing the rate of bacterial and biofilm regrowth over 100 times. Now we have in vitro, in vivo, and we actually have clinical trials showing the efficacy of this product. This particular in vitro study was done at the Center for Biofilm Engineering at Montana State University, which is an international center for biofilm research. And basically what they did here is they compared Blastex, this new biofilm disrupting wound gel, to other products commonly used in wound management. And they tested against biofilm formed by Pseudomonas as well as Staph aureus. And they were able to demonstrate a 4 to 6 log reduction of those microorganisms with Blastex compared to much smaller reductions in these other products. Now, this is an in vivo mouse study that was done at Texas Tech. And basically what they did is they took Pseudomonas and they took Staph aureus, 2 common infecting organisms in chronic wound care, and they inoculated the backs of mice with these bacteria that had been genetically modified to luminesce under special lighting so we could actually see them. And in the first 4 mice, you see this is just 24 hours after initial bacterial inoculation. So they haven't been treated yet, and the bacteria and biofilm are growing on the backs of these mice. In the next 4 mice, this is 24 hours after the Blastex has been applied to the treatment group on the right. And you can see that with both Pseudomonas and Staph aureus, the biofilm is completely gone. Whereas in the control group, it still exists, it's still growing. And then in the last panel, 48 hours after treatment with Blastex, again, in the control group, the biofilm is still there. The Blastex group, you can see it has sustained effect of biofilm disruption over time. It still is not present. So now let's describe the randomized controlled trials looking at the use of this biofilm disrupting wound gel in patients with chronic wounds. The first study was published earlier this year in 2018 by Kim et al. And the objective was to study the use of a biofilm disrupting wound gel to determine if disrupting this chronic wound biofilm would be therapeutically efficacious. This was a 12-week prospective randomized clinical trial with 43 patients. Half received the biofilm disrupting wound gel and half received a broad spectrum topical antimicrobial ointment. Actually, triple antibiotic ointment is what it was. And treatment failure patients from the control group were allowed to cross over to the experimental group at 4 weeks if they either got worse or failed to improve. Average wound size, 11 square centimeters. Average wound duration, these were chronic wounds, 21 months, and average patient age was 61 years. All patients received weekly debridement. And the endpoints were percent wound area reduction and wound closure rates at 12 weeks. So when we look at wound area reduction, the Blastex group had a 71% wound area reduction versus the control group had a wound area reduction of 24% at 12 weeks. And this was highly statistically significant at a p-value of 0.001. That resulted basically in a 3 times greater area reduction for patients treated with Blastex. When they looked at wound closure rates, in the patients treated with Blastex, 52% of patients had healed at 12 weeks versus 17% in the control, and this was also statistically significant. This resulted in a relative increase in healing of 205% for those patients treated with Blastex. The second study was published by Wolcott in the Journal of Wound Care in 2015. This was also prospective, randomized, and involved 45 subjects with chronic wounds of over 1 month's duration. These these patients were randomized to receive either a Monday, Wednesday, Friday application of Blastex, a Monday, Wednesday, Friday application of a custom topical antibiotic per culture result. So each subject had their wounds cultured, and then a topical antibiotic gel was prescribed based on that culture result. And then the third group had a Monday, Wednesday, Friday application of Blastex plus the custom topical antibiotic. There were no differences in demographics between the groups, and all wounds were debrided weekly. And the endpoint was percent of wounds with 50% wound volume reduction at 4 weeks, which in the published study, they actually referred to that as quote unquote wound closure. So you'll see that in the next slide. But what they're really referring to is the percent of patients or wounds with 50% wound volume reduction at 4 weeks. So in looking at those results, the patients that received only the custom topical antibiotic reached, 53% of those reached the endpoint at 4 weeks of 50% wound volume reduction. In the Blastex treated group, 80% of subjects reached that endpoint. And then in the group where they received Blastex and the custom topical antibiotics, 93% achieved 50% wound volume reduction at 4 weeks. Now, what's important is that the difference between the Blastex and the custom topical antibiotics alone was statistically significant. And the difference between standard of care, again, the custom topical antibiotics and Blastex, and the custom topical antibiotics alone was also statistically significant. You can see that with those p-values. However, no statistical significance between the Blastex and the Blastex plus the custom topical antibiotics. You saw the wound closure rate improve when the custom topical antibiotic was added to the Blastex, but that was not statistically significant. So the Blastex alone achieved very good wound closure rates. So let's talk about how to use this new biofilm-disrupting wound gel. Well, it's indicated for almost any type of wound: pressure ulcers, partial and full thickness wounds, diabetic foot ulcers, leg ulcers, post-op wounds, first and second degree burns, grafted and donor sites. And as I said, it is a gel. You want to apply it to the wound in a 3 millimeter layer, which is really about the thickness of a nickel. This is very easy for patients to do, and that's how you would teach them, is just apply it the thickness of a nickel across the wound bed. So next, let's talk about how to use it. Well, you want to cover it with an appropriate dressing based on the amount of exudate. And this is really what I do in my everyday practice when I'm deciding what particular dressing to use. I look at the amount of exudate. So if you have a patient with high exudate, you're going to apply the Blastex, and then you're going to cover it with an exudate absorber to handle that high exudate, with or without a contact layer. So you might use foams, gauze, absorbent pads, hydrofibers, etc. Let's say you have a wound with low exudate. Then what I recommend is you apply the Blastex, and then you cover it with a petrolatum-based contact layer just to make it more moisture retentive. Or you might use a foam with a film backing, and you're using that film backing again because the addition of the film backing decreases your moisture vapor transmission rate and makes the dressing more moisture retentive. So again, it's very simple. You just use bandages based on the amount of drainage. You can use it before applying a negative pressure wound therapy sponge. In our practice, what we do is we apply the layer of Blastex to the wound. We allow it to sit for 15 minutes, and then we do not remove it. We leave it in the wound, and we then apply the negative pressure wound therapy sponge. And then you want to apply it every 1 to 3 days, depending on your dressing change protocol. In our practice, for our patients in compression wraps, we will use the Blastex with the appropriate dressing, and then we change the compression wrap twice weekly. You should not use Blastex if there's any history of allergy to any of the ingredients. You don't want to use alginates with Blastex because the calcium in the alginates can affect the Blastex. And don't use with other antimicrobials mainly because it's just not necessary. So let's go through some case studies. So this first case study was a 65-year-old diabetic who had an exostosis, so some bony growth, removed from the base of the fifth metatarsal. And then they closed that with a flap, and the entire flap necrosed, unfortunately. So the flap was debrided, and he was referred to our wound clinic, and this is what the wound looked a day or two after surgery. The wound looked like a day or two after surgery. Now, what's important here is that you not only treat the wound, but you treat any potential issue that could be interfering with wound healing. So in this case, this patient had chronic edema, so we had him in a compression wrap, specifically an Uniboot. And then he was a diabetic. We wanted him to off-weight this area. We did not want any pressure put on this wound. So we had an orthotech make a cast, a contact cast, and then he clamshelled it so that we could remove it Mondays, Wednesdays, and Fridays for his negative pressure wound therapy dressing change. And then the patient got a knee scooter, so he was completely off-weighted, edema was controlled. I should say that his pulses were fine. He had good arterial flow. So we started negative pressure and all those other treatments, and we did negative pressure for about 5 weeks. And we got the wound to fill in, and it had shrunk, and it got to this area right here where it just wasn't moving. For the next 2 weeks, the wound really wasn't epithelializing. There was no action occurring at the wound edges. We still had him in a compression wrap. We still had him in the contact cast. He did not look clinically infected, but he was draining a lot. There was a lot of green drainage. And so we said, well, let's try some Blastex. So we put the Blastex on the wound, covered it with a contact layer, foam dressing, compression wrap, clamshell contact cast. And this is that wound healed 16 days later. So we really felt that, again, addressing biofilm in the wound turned things around and got this wound to heal. This next patient was an 82-year-old with a chronic venous ulcer, and in fact, his wound at one point was 5 times this size, and we had gotten him healed down quite nicely with compression wraps. He had good arterial flow, he had good control of edema, yet he continued to drain this high amount of green exudate, and there were no clinical signs of infection, no cellulitis, no pain, and he just wasn't progressing. We got him to this point, and the wound would not heal. So again, we decided to try Blastex, and so we applied it under a foam dressing, changed the compression wrap twice a week, and this is 1 week later. And what's significant here is that we saw the green drainage reduce to where it was almost gone. And then I also saw new epithelialization. So the edges started flattening. There was a new area of epithelialization along the top of this wound. And it was quite surprising how much he improved in just 1 week. This was an 86-year-old patient who had received 4 weeks of radiation therapy for a recurrent squamous cell carcinoma on her leg. She also had coexisting venous insufficiency with edema. Pulses were normal. So she was referred to the wound clinic 2 weeks post her radiation treatment. And I noted that she had a lot of edema, so she was started in a compression wrap. Now, looking at this wound, if you look at the very central, about 2 centimeters of it, that's a full thickness wound there. And that's where the SCC had been, and that was where the high dose radiation had been. But she also has surrounding radiation dermatitis as evidenced by denudement. So again, we started her in a compression wrap. And this is about 6 weeks later. She really had not improved in terms of that central wound. The surrounding radiation dermatitis had completely reepithelialized, but we just could not get this wound to make any progress whatsoever, and that was despite very, very good edema control. She continued to drain high amounts. Now, many of you would say, well, why didn't you refer her for hyperbarics? Because hyperbarics would be an indication for this patient. At this point, I would consider this late effects of radiation from a diagnostic standpoint, and that she would be a candidate, but she refused. She just said, there's no way that I can drive and have a 5-day-a-week treatment. Is there any way you can do anything else? And I said, well, let's try the Blastex. So we put Blastex on, covered it with a contact layer to maintain a moist wound environment and non-woven gauze, and just changed her compression wrap twice a week. And this is 2 weeks later. Her wound actually was smaller, and the wound bed actually looked a little bit better. Her exudate was decreased. This was 4 weeks later. And then she was completely healed after 2 months of treatment with Blastex. Now, she would have had hyperbarics for 2 months as well. So we were able to save her from having to have that treatment and able to get her healed. This is another frail elderly patient of mine, 83 years old, had had a leg ulcer for 4 months, etiology unknown. She couldn't remember how she sustained it. She was a 50-year smoker and was currently smoking a half a pack of cigarettes a day and absolutely refused to quit. She did have biphasic dorsalis pedis pulses and chronic edema. We did do further vascular studies. She did see a vascular surgeon, and it was felt that she had adequate arterial flow for healing. The wound was debrided, and she was put in a compression wrap. This is about 5 weeks later, and although the wound is cleaner, the wound size really and her edema is better controlled. The wound really hasn't gotten that much smaller. Nothing much is happening. So we said, okay, let's try some Blastex. We covered this with a collagen ORC dressing and a foam dressing, continued her in twice-weekly compression wraps. And this is a week later. The wound looks healthier. It's starting to get smaller. 4 weeks later, the wound continued to improve. 6 weeks after starting Blastex, and then completely healed after 10 weeks in this frail 83-year-old smoker. And then the last case is a 62-year-old with a diabetic foot ulcer, status post transmetatarsal amputation a few years prior, who presented with this ulcer on the distal amputation site. Pulses were normal. They were triphasic with a Doppler, easily palpable. He was in a pair of regular shoes and was using a sock in the distal part of the shoe to fill in the shoe. He had gotten orthotics years before and didn't like them, so he had fashioned his own shoe, and his orthotic was a sock stuffed into the shoe. So this is, at the first visit, contact cast all of our diabetics with foot ulcers that are candidates for that. And that means they have to have good arterial flow. They can't have significant infection. They have to be compliant with off-weighting. They have to be able to return to the wound clinic weekly for cast changes. I Blastex, just covered it with a piece of non-woven gauze and contact cast. In our clinic, we don't use a lot of different dressings under the contact cast. Doesn't like that, and we have really good results with just covering the wounds with a piece of gauze, and so that's what we do. So Blastex, non-woven gauze, and this is a week later. You can see a nice, healthy pink bed. The wound is already smaller. Granted, part of this is just being in a contact cast, but the addition of the Blastex, I believe, gives us some protection against infection and biofilm. This is 4 weeks later. His wound was about 2 millimeters across, and he was completely healed at 5 weeks. And we now routinely use Blastex with contact casting. And then one more case. This 81-year-old, 1 year history of this leg ulcer, and she had significant edema secondary to uncontrolled congestive heart failure and venous insufficiency. She had good pulses. And this is the very first time we saw her. And you can see that this tissue just is poor quality. It's mushy, it's friable. She doesn't have any overt signs of infection. I mean, there's really no cellulitis. She's got some hyperpigmentation the skin, but there's no infection there. So we debrided the wound, I curetted the wound bed, started Blastex right away because I felt like a patient that's had a wound for a year probably has a lot of biofilm there. In fact, remember, we know that biofilm starts to form within 24 hours of wounding. So we wanted to use Blastex right away, covered with a contact layer, a foam dressing, and a compression wrap. And by the way, I did contact her primary care physician about getting her CHF under better control. And this is a week later. 2 weeks later. At this point, she's got some very healthy appearing granulation tissue, still a little bit of fibrin in there, but we've got that kind of peninsula, new epithelialization has enlarged in the center of the wound, and the wound is looking a lot healthier. So in closing, we've learned a few different things. We've learned that biofilm interrupts wound healing, and it mainly interrupts wound healing because those increased bacterial counts, that constant release of bacteria back into the wound causes a prolonged inflammatory response and halts wound healing. We've talked about what biofilm is. It's a community of pathogens protected by that polymeric structure, which is very strong and very resistant to the majority of the treatments that we provide. We've talked about those current trends in treatment using debridement, topicals, dressings, which we know are not fully effective against biofilm. And then we've reintroduced a new therapy, a new biofilm-disrupting wound gel designed specifically to dismantle that extracellular polymeric substance, that biofilm structure, that armor that protects the pathogens. It disrupts that, and then it kills off the pathogens, and then it defends against reformation of that biofilm. This concludes my presentation, and I want to thank you for your attention.